on to the next session. We have here Dr. Anil RadhakrishnanD, who is the head of the Department of Cornea at the hospital Kochi. He will be talking to us on refractive procedures, prerequisites. What do you say?
On the last day of the state conference. Quite interesting. Okay. So I thank Dr. Aditya, Dr. Soumya, and the chair, Dr. KSOS2022 for giving me this opportunity to speak to you in this platform. So I'll be trying to address corneal topography used, and as biometry, if you make a mistake, your refractive surgical patient would be very unhappy. So I don't think in the 10 minutes I can be covering all the components of the refractive workup. So I'll be just confining myself to topography. And that too, I may not be able to cover it completely. So first I'll tell about the principles. If you look at this picture here, you can see a series of buildings over there and the waterfront, in waterfront which is in the forefront. So if you look at the image of the buildings there, if you see almost everything is like a mirror-like reflection. But if you look at the antenna of these, you can see that there are imperfections here. Why are those imperfections present? That's because there are imperfections of the surface. So that is precisely the principle of topography, that your cornea acts as a convex mirror. In this scenario, in this scenery, you're seeing it as a plane mirror. The cornea, one advantage is that you're seeing it as a convex mirror. And also, if you know the size of the image and size of the object, actually you can calculate or reduce the curvature of the surface. That is the essential principle of keratometry as well as topography. So cornea is a convex surface, and actually the images are magnified. So the minor imperfections that you have would be magnified. The disadvantage of keratometry is that it measures only a very small central area, only 2.5 millimeter area, and it makes a big assumptions that cornea is a symmetrical spherocylinder. So in a normal shaped cornea, it works perfectly well. But if you have a abnormal cornea, that is not happening. So in this video keratoscopy, you have this multiple illuminated mice that are projected onto the cornea. There are multiple video cameras which can take the images of the reflection on the cornea, like the central one is there, two on the sides, and the relation of the point to the central fixation point is taken. So, and the calculation is based on multiple different type of algorithms. So along one ring you have about 256 points. So this is, I'm talking about Placido topography, and that too what we have is the Atlas. Some of the systems may be slightly different. The number of illuminated mice may be more, but essentially the principle is the same. So based on these algorithms, the computer gives a color coding to the data that is there. So you have to look at basically the numbers below. You have to look at the K values, the steep value and the flat value, average keratometry, then cylindrical power. Then there is something called SRI, surface regularity index, and surface asymmetry index. So I'll be just touching upon it. But I think it's very important to realize that these color codes, there are certain gradations for the color codes. Say between 35.5 to 50.5, you have a variation of color only at 1.5 diopters. So if it's a small variation and it's only 1 diopter astigmatism, so you may not see much of a color change. Beyond that, you have about 5 color change occurs in every 5 diopters. So it's very vital that the patient is aligned properly. The lateral canthal should be aligned to the lateral canthal marker. And when you have a good keratograph, there is only minimal shadow. There are no dry spots. You can see the rings all around. So you have to look at this before you to procure the image or you save the image. That's very important. There should not be any pooling of tears, and the ring should be actually continuous. So this is one patient in whom there was like dryness. To see that there are discontinuity in the rings, and because of that the corneal surface is taken as bad. If you have pooling of tears, what will happen? You will have inferior steepening like this. So, but the position of inferior steepening will prompt you to say that this is usually a problem. So if the patient is tearing and there is pooling of tears like this, you can see inferior steepening like this, which can be a misrepresentation. This is a keratograph I have taken asking the patient to look up. So if the patient is not looking straight, so you look at the right eye, whenever you're taking the image, you have to go back and look at the keratograph. If you see that the patient is looking up and the image is coming like this, you can see that the cornea on the right hand side is totally abnormal. Why is it so? Because it's only a problem with the faulty capture, nothing else. So there are certain abnormal patterns that we see and there are certain normal patterns also. And there is a grey area between normal and abnormal. It's not black and white. You cannot say for sure that one is abnormal, one is perfectly normal. So that grey zone is quite high in topography. So I'll just go to some of the images. This is one topography of a patient who has some about 1.5 diameters of astigmatism. You can see that there is a bow tie-like pattern. This is the superior steep pattern. The superior cornea is slightly steeper compared to the inferior cornea, but that again can be perfectly normal. So astigmatism is generally symmetric. You look at the two bows of the tie, that will be symmetrical. There will be something like an hourglass or a bow tie shape. And it can be with the roll, it can be against the roll, it can be oblique also. But if it is grossly asymmetric, then you know that there is a problem. Usually it indicates a pathology. So that is it. So the other thing that is important is the asymmetric bow tie pattern. If you look at the two bows of the tie, they are in one line and they are symmetrical, as I said before. If it is grossly asymmetric and if the bows of the tie are not in one line, there is something called a skewing of radial axis. Very minimal skewing can be normal, but if it crosses 12 degrees and definitely if it crosses 20 degrees, that is definitely pathological. A normal cornea cannot have a pattern, topographic pattern like this. So this is my own topography. I have done this. I have astigmatism with the roll astigmatism. You can see that the superior part of the bow tie is slightly more steeper than the inferior part. What about this? This is you can call it an irregular pattern, but absolutely no pathology seen. We have to look at other parameters also. So when you see a patient like this, you see that there is a small amount of steepening and that is remaining in only in one small area, paracentral area. So this, just go back to the keratograph, repeat the topography. Maybe you can put a lubricant or ask the patient to blink a few times and then do it. Lubricant has a problem. Sometimes it will iron up these small defects that are there on the cornea. So actually you should ask the patient to blink a few times and then repeat it. If still it is coming abnormal, then only you go for the lubricant. That's what I do. So you ask the patient to blink a few times and take it, it's perfectly normal. So it's absolutely normal. So keratoconus is characterized by asymmetric bow tie pattern, as I mentioned before. There can be gross asymmetry between two eyes. In one eye, it can almost just be normal, or we can say small hint of inferior steepening in one eye, and other eye can be very, very high keratometry values, the gross red colors you see here. So whenever you see these red colors, you should look at the corresponding keratometry readings below. For example, you look at this color, the color corresponds to around 50, more than 50, definitely. So this is what you should look at. Just because you see a red color, the scale can be different. Sometimes 45 may be shown as red also. So you should look at the color and the corresponding value there. Then only you can correlate. So this, I don't know, it's coming again. So I don't think I'll go into the details of this, but we have other systems with which the thing what I spoke about right now is only about the anterior corneal curvature. There are other data also which can be derived with a newer machine. This is the Visante OCT machine, in which the first image shows the anterior curvature data. Then you have the pachymetry, both absolute as well as relative pachymetry data. Then there is elevation data. So based on all this, you know that it is abnormal or normal. So this is a patient who came for a premium IOL surgery. Actually, this is a patient who had a keratoplasty some 20 years ago. And he asked whether it is possible to do a multifocal IOL. So what do you think? So if you look at the central 3 millimeters of the cornea, you can see multiple zones there. One area it is The keratometry is coming to somewhere around 24, 25. Here it is coming to 45. Here it is 42, 43. So it is a very abnormal cornea. So he is not a good candidate for bringing IOL. If he badly wants it, you can ask him to take it, but at his own risk. But definitely, he can assure him that he is not likely to have the full advantage of multifocal IOL. What about this? This is a perfectly symmetrical bow tie pattern. Slightly oblique, but it's perfectly normal. Usually very likely to have excellent results after surgery. What about this? This again, there is some, he does not have actually the K values are well within normal limits, but you can see that if between the two halves of the cornea, it is not perfectly symmetrical. So you can, like if the patient wants, he can go for a pre-IOL, but you have to caution him that the result may be suboptimal. Okay. The other conditions like contact lens induced warpage, it was typically seen with rigid gas permeable lenses, but nowadays very rarely used because of the proliferation in the lens market, and it is characterized by inferior steepening exactly in the inferior location. Even soft contact lenses can cause imperfections. Like this is a patient who came for LASIK workup, found that there is some irregular pattern. So the Kleist Smollett software was telling that there is a keratoconus suspect-like a pattern. But if you see the keratograph, there are imperfections there. So I just put the patient on lubricants, and after 2 weeks, 3 weeks, it was consistent, and even the pentacam was normal. So we went ahead with the procedure. Sometimes you can get a descended ablation, and in such, like in a perfectly done LASIK, the area where it is ablated will be right in the center. It will be encompassing the central 3 millimeter area. So if it is tilted to one side, there can be glare and halos to the patient. So more importantly, it's useful for you to understand that it's because of the decentration. In keratoplasty again, we can assess the suture thickness, suture tightness based on it. Like if you see that there is a pattern like this, you know that the suture here is tight and you can remove that. I'll just mention about OpScan and Pentacam. I don't think I have the time to do it. But in this, there is, in all this, while what I was mentioning was about corneal topography. Now, with the advent of OpScan in 2000s, and now we have Pentacam, Sirius and other imaging, you can have a look at the curvature of the posterior curvature also, and you can have a good assessment of the thickness of the cornea also. So it keeps a best fit sphere, and you look at the points which are above it and which are below it, and based on this the images come. So you have an anterior float, then you have a posterior float, you have certain normal values, and if it is beyond that normal values, you have to consider it as abnormal. Obviously, you have to go look at the axial curvature map and the pachymetry map also. If it's time, let me know when you have crossed the time limit. Is it over? Yeah. Okay. So I'll cut down in the interest of time. Thank you so much for the opportunity.
Thank you, sir. It was a because it takes more than for us to know only 3 to 4 months about all these maps. Once again, I thank. The only thing is, sir has shown, which is the basic for it. That is the anterior topography when it is combined with the Requisites OCT, which also gives